It is just a huge honor for me today to be podcast interviewing Dr. Kenneth Byron Wiltbank, DMD, who attended the School of Dentistry at the Oregon Health Science University and later completed the endodontic residency program at University of Texas Health Sciences Center of San Antonio. He is a diplomat of the American Board of Endodontics and an active member of the American Association of Endodontics. Dr. Wiltbank also serves as the AAE representative to the American Dental Association's Code Maintenance Committee and to the American Association for Dental Consultants. He is appointed as an adjunct associate professor of endodontology at the Oregon Health Sciences University School of Dentistry, Department of Endo, and also serves as an occasional guest lecturer. He is the owner-operator of an endodontic practice near Portland, Oregon, and in Astoria, Oregon, and is a member of the American Dental Association, the Oregon Dental Association, and the Clatsop County Dental Association. Dr. Wiltbank attended dental school at Oregon and graduated in the class of '98. After 7 years working in Tigard as a general dentist, he returned to school at San Antonio, where he completed residency in endo. I always find the specialist very more interesting when they get out of school and work for a while as a general dentist and then go back. And when I went to MBA school, the kids who rolled right out of their 4-year business degree and they thought it was another textbook. But everybody in that class who'd gone out and worked in the real world, they had really interesting questions and perspectives. So what were you doing as a general dentist for 7 years and said, I just can't get enough of these molar endos?
That's a good question. We had started, me and a dental school buddy, Scott Walker, had started a practice in Beaverton, Oregon, and we were doing real well and having fun. And I just got the bug to go back to school. I had always enjoyed school until the very end. And then I was so sick of it, I couldn't see straight. And I just needed to get out of there. But after about 7 years in, I got the 7-year itch and I felt like going back to school. And I looked at all my CE that I took. I enjoyed CE, but I saw that like 60 or 70% of my CE was all endo, and that must be what I liked.
Well, it's very tough because, we've got a couple of new specialties this year. There was 8 of them when I got out of school, and now that list is grown to 12. And the in demand, oral surgery and endo are the top 2. I mean, and what's funny is public health is a specialty. No one really talks about it, but when someone comes to your dental office and they're in pain and you can't extract a tooth or do a root canal, then that's why we see 8.5% of emergency room visits odontogenic in origin. And I just couldn't imagine breaking my leg and showing up at a hospital at 1 o'clock in the morning. They say, I'm sorry, Kenny, we don't do legs. You're like, what the hell? I thought you were a doctor. And then what really concerns me, why I'm so glad you came on the show, is these kids come out of dental school with all these student loans, and half the class has only done a molar, and they're already done. They already tell you, they go, I hate molar endo. And then they want to go into Invisalign, bleaching, bonding, and veneers, which is kind of a glorified nail salon. I mean, what would you say to some young kid who got scared, like bit by a rattlesnake on endo and doesn't want to see it again, but they have a dental office in a small town, and they're the only dentist?
That's a good question. We answer that question at the university all the time. I work with the undergrads, the 3rd and the 4th years, who are doing their first endo experiences. We try to get them so that they're doing anteriors and premolars to start with, but they all get into the molars, and some of them get the bug, and some of them don't. But we always encourage them. You got to learn how to do it. You got to be able to do a pulpotomy or a pulpectomy. Just don't get shy of it. You have to learn how to be a doctor, like you say. I like when you say that, because that's part of being a dentist. You got to learn how to get the pulp out of there.
That sounds like I knew you'd answer that good, because you were the oldest of 6 children, and I've noticed all the eldest children, they were all many adults when they were kids. You know what I mean? They just
there you go.
They just had to take care of the younger 5. My gosh, first of all, everyone wants me to ask all the guests that come on the show. They want me to ask you first out. Would you, Kenny, take the vaccine for yourself today?
I already got both doses, Howard.
So I'll take that as a yes. I did too. Man, why? I can't believe how much pushback there is on that. There's big threads on Dental Town. My staff doesn't want to get it. I knew a quarter of America was anti-fluoridationists, anti-vaccinations, but when I found out that people who are LPNs in nursing homes don't even want the vaccine, and this is no surprise to you. You're in Oregon, which I don't ever want to talk about religion, sex, politics, or violence, but it sounds like Oregon doesn't want, they're what would you call it? Just anti-authority?
It seems like that sometimes. We still are having riots downtown. I've driven downtown to see the shenanigans downtown every month during this whole COVID era, just to see the repercussions. And it's hard to know what's going on, but at the same time, I don't know how to fix it. I think people don't know where to go for what they believe is true, and then go with it. I decided I was going to go with the medical establishment, and if the doctor tells me that's safe, I'm going to go with that.
Yeah, and that comes from you and I having a generation of trust. Like, I remember when I'm working on water fluoridation campaigns, you'd give them literature from the CDC, and 1 in 4 Americans say, oh, they're just a shill for the pharmaceuticals. And it's like, right. Dude, I've gone to Atlanta. I've met them. They work really hard for a lot less money than if they just go out in private practice. But it just seems to be a massive systemic loss of trust in institutions, whether it be, like, my sisters are nuns. I mean, the turmoil the Catholic Church has gone through, government, the CDC, water fluoridation, vaccines. It just seems to be a lot of loss of trust.
Yeah, I think that's a good way to put it. And it's hard to know how we're going to gain that back. Who's the one that's going to help us trust again and help people believe in one direction or the other or fix it?
Well, then I'm going to ask you some very tough, controversial, trusting questions. A lot of general dentists who really like their art and really do it, they obviously want to do it to the level of the specialist. And so when oral surgeons started switching from panos to CBCTs, the implantology guys and the wisdom teeth guys jumped on. Well, you guys got a lot of expensive equipment that you can buy. Like, there's a Son Endo out there that's buku bucks. Did you invest in that? Is that part of your regular deal?
We purchased it. We took possession of it recently, and so went through the training. And I like having it in my my quill of arrows, if you know what I mean. And but it's quite a learning curve. It's not for the faint of heart to take it on and learn it. At the same time, after you get it down, it's fairly simple. So it was a big jump in, and I like it when I want it, and I don't use it on every case. Although I'm sure there would be lots of people listening that would say you shouldn't use it on every case.
And first, let's see if we agree on the math. I mean, I've noticed that dentists have had debates on Dental Town since 1999. Now it's 2021. That should have been solved if you had access to more data, like from insurance companies, like just something simple, like what lasts longer, an MOD composite or amalgam. Well, Delta and Blue Cross and Blue Shield, they must have 1 billion claims on this. We would know the answer. But I was lecturing to a bunch of insurance dental consultants in Florida, and they wouldn't post their stuff on Dental Town, but they would show me, but they wouldn't let me print it in Dental Town. But they were showing me that when endodontists do molar root canals, in 5 years on molars, 5% of them are extracted. And when general dentists do it, it's 10%. So that's really the difference in endo. Did you agree with those numbers, or do they seem normal or rational?
I think that seems intuitive. Plus, I've heard you say that on the show before. And so I've thought about that a fair amount. And endodontists, when we think about that, we think about our success rates in terms of high success with really hard cases too. So the difficulty level of cases makes those numbers difficult to balance as well. And so, if you have a better success rate in way harder cases, then the spread might even be bigger. At the same time, we know that there's a ton of general dentists that are good at root canals, and there's no way that all the endodontists can get to all the root canals. And so you have to have general dentists to know how to do this. It's important to teach them.
So what % of your root canals would be retreats as opposed to initial treatment?
You go through streaks. You basically have a small sample size problem with that question, but because it's one guy's practice. But I always tell people it's around 25% to 30%. is second time arounds. And sometimes those are really, really hard ones. And sometimes it's pretty straightforward and simple. But it really, you have to figure out why it failed in the first place before you can know if you can fix it.
The one thing on the Son Endo thing, you know, it's really something for cleaning. It's not finding the canals. It's not working them up to a 25 or something like that, which it just seems intuitive to me that the number one cause, the fail of a cause of root canal is not getting all the infection out, and the easiest way not to get all the infection out is miss one of the canals. Do you think miss canal? So would Son Endo address that? I mean, if you only found 3 of the canals and did Son Endo, would it clean out part of the 4th?
Partly. Some of the concepts is right. 2/3 of those that have MB2, 2/3 of those join somewhere in the canal system. And so it will get down up into MB1 and then sideways over to MB2, but it's not really going to necessarily let you find the orifice to MB2. But there are people that are using it in a way where they kind of bubble it up and it breaks up some of the orifice, and they do find the orifice a little easier. So there's a little bit to that it can clean that MB2 even if you don't find it, or help you find it. So there is a little bit of magic to that. And
what when you are back at Oregon State and you see failures, what do you think the general dentist listening to you right now? What do you think is the low hanging fruit of how they could improve their endo game?
My biggest low hanging fruit is I'm always surprised when I talk to the patient. You know, here's a dental dam. Have you ever had a dental dam on there before? They've got 5 or 6 root canals in there and they've never seen a dental dam. So the lowest hanging fruit for me is using the dental dam. To me, that's got to be for safety and for cleanliness and you know, standard of care.
Some of the things that I notice outsiders do not like about the way our profession handles root canals is the routine. And this is sad, it's a laugh to say it, but I mean, a lot of dentists, including a lot of my friends, every time they do a root canal, it's a standard pen BK and 16 Vicodin. I mean, every single time. Yeah. So I want to ask you, if you did 100 root canals, how many of them would just get a standard script of pen BK and Vicodin?
None of them would get a standard strip of it, but I'd say I prescribe probably 5% of my patients antibiotics right after treatment, and another 5% maybe during their first few days of healing. So 90% of people don't get antibiotics. And then it's probably 3 to 5% get a narcotic afterwards. And usually they're people that can't take the NSAIDs. And so we worry about those folks. And especially if they have a history of having lots of pain after root canal appointments or dental appointments, I'm going to give them a little bit of narcotic to get them through the first couple of nights. But we're talking about 8 pills. You know, it's a very small prescription.
Yeah. You know, when I got out of school in '87, I had a blister on my thumb and my finger from doing that all day for years. And then when this engine-driven NiTi came out and John McSpadden, he just passed away. I can't believe he just passed away. That was I flew all the way to Chattanooga to get rid of this blister on my finger and thumb. But back then, the big problem was files breaking. And it was everybody's nightmare, and it was everybody's scare, and things like that. Has the file breakage problem gotten better over the years?
I think it's gotten a lot better. I still occasionally have a file break myself, even though I do them every day, all day. But I probably break just a few every year, and I get most of those out. But the nickel titanium metallurgy that we have right now is significantly better than even it was when Dr. McSpadden was teaching you how to do it. So the original profiles, I still keep some around for retreatment purposes. I like the stiffness for certain cases, but I use some of the newer metallurgy, and that's the real trick is you have to upgrade your metallurgy in order to take advantage of the latest non-breaking files.
So are you agnostic on your file, or do you are you like all Dentsply Tulsa, or is there a brand?
I have my preferences for sure. I like the file quality from the Dentsply what is it now?
Tulsa Dental.
Yeah, Tulsa Dental traditional company. There's another name that owns it now, but I love my reps that come to visit me, and I love their quality of product. But I also love that another brand that people that compete really strongly and really kind of harshly against Dentsply sometimes. But I really love their product of the Edge X7, and so that's my favorite. It's kind of, I always say endodontists are like golfers. If you like your clubs, you don't want to get new clubs. You want to keep those clubs and just keep hitting on those clubs.
So who makes the Edge X7?
Edge Endo.
Oh, Edge Endo. That's my buddy out of next door, New Mexico.
That's right.
Chuck.
Goodis.
Chuck Goodis, yeah. And there was another one of the other greatest endodontists that ever lived was last name is Goodis.
Right, and I can't remember his first name, but he's another very well-known endodontist.
Yeah, so I told Chuck that it's must be genetic with that name. But why do you like Chuck's file?
That file, ever since I picked it up, I think I've only broken like 3 or 4 in like 7 years. You know, very few. You know, endodontists always say they never break a file, but certainly I have, but not very many. And that one is just so smooth. I also like the price because I only do single use. So everybody gets a new file. I don't use my files over again. And so I feel good about being able to toss them out when I'm done. And they are just very smooth in my hands.
Huh. That is interesting. And do you hand file to a certain size, then switch to engine driven, or how do you do that?
Yep, that's what I do. I keep C files on my sponge, the 6, the 8, and the 10. I keep a couple of stainless steel files on there too, a 15 and a 20, but I try never to use those if I can avoid it. In most cases, don't. Usually I get an 8 or a 10 at least to the working length, and then I'll switch over to the engine driven.
It's funny when you talk to general dentists, they always talk about obturation. I remember when Thermophil came out, and it was all about obturation. And it's kind of funny because when you talk to endodontists, they only talk about finding the canals and cleaning and shaping. And the dentists always talk about obturation, and they always want to see the final film, like you seeing the 2-dimensional final film means anything. Why do you think that is?
Well, you know, endodontists, when we found the canal, it feels like it's over. It's kind of like you caught the ball and you're on the 10-yard line and nobody's in front of you. And the obturation's that last 10 yards, but it's already done. And so for the endodontist, the hard part's all the beginning and the obturation. You got to do it right, but it's already done. But I don't think that it's when you're still learning and getting really good at that obturation, the obturation is still part of the adventure. But for us, that last 10 yards and nobody in front of us, it's kind of like, it's already done. It's in the bag. But looking at the x-ray at the end, I think that's almost like a painter looking at the wall they just painted. They just want to see how it turned out. You know, how did we do? How did we do? And it's a little bit of a gratification kind of thing. Like, yeah, we nailed it.
Yeah, so it was that the old guy was Harold E. Goodis, professor emeritus,
Goodis.
Department of what a legend, Department of Boston University.
There you go.
I shouldn't be asking this of an Oregon West Coast guy, but seems like Boston University for a century has been just huge in endo. Does it seem that way to you?
Yeah, there's definitely kind of like a Boston contingent in the endo world, and they do a really good job with their alumni association. They keep guys and gals in touch, and they all had a good time in their program.
They all had a good time in their program?
Yeah, I think they work them real hard, and they educate them real well.
Now, this sounds bizarre to ask, but in London, Paris, and Tokyo, the government insurance scheme only gives you $100 US for a molar root canal. And when I go there, even doctors in Japan tell you, well, you can't do a molar root canal because, $100. Land in Tokyo is $1 million a square meter. And you want me to do a molar root canal for $100? Reimbursement is a big deal. So what a lot of these people do with reimbursements and PPOs is the insurance will pay for a post. So it's a molar root canal. There's 3 roots there. So they'll put a post in each one of those roots because the insurance will kick in another 60, 80, $100 or whatever. But then some people say that the only function of a post is to fracture the root. So,
Yeah.
so how do you balance that post? Again, the question to you is, if you did 100 molars, how many of them would have a post?
That's a good question too. So I'm not a post guy at all. And I use the theory of especially molars. I'm not talking about little tiny premolars or anteriors that have to have a post, but for molars, I don't hardly put any posts in. I use the old adage of, if you can put a filling in without the post, it doesn't need a post. And so if there's enough to hold on to the filling, I do that. I probably put in 1 or 2 posts in a posterior tooth a year at the request of the dentist that I work with. Being a general dentist for 7 years, I can still do all that stuff at a high level, I think. And so I still will do it. And some of my dentists, they don't like doing it, but they know that it needs a post. And so I'll put it in for them. And so probably 1 or 2 a year. And then in the anterior or the tiny, teeny premolars, sometimes they'll need them a little bit more. But there is another school of thought that some people have, and they read the literature a little bit differently. And that is, they feel like if you bond in a very narrow gauge post, that you can give some strength to the root. And that's for the little skinny teeth. And so I haven't been totally swayed by that argument, though.
So it looks like the DSO world is coming to Endo. They just launched Endo One Partners.
I saw
the first ever endodontic partnership organization. Endo One Partners adds 31 new practices to growing platform in 2020, strengthen its positioning in the endodontic sector. The endodontists that I know out here that are my age, they were already on a track to retire in 4 or 5 years, not for them. But do you see this as something in the future, the next generation, where there's just advantages of a group participation, having that layer? Or do you see the endodontist more like an American cowboy who wants his own ranch and doesn't want to play with others?
I like that analogy. It seems somewhat that DSOs will be inevitable. And I've listened to plenty of people talk on your show and other podcasts about that. And I appreciate the way that you presented how it's good for business, because it makes you play up. It makes you play up to the competition and be ready and willing to get better in your business. So I do think that people in the next generation are drawn towards the things that the DSO does for you and doesn't make you have to do every day, that are hard as being a business owner. At the same time, for me, I've already tried those things. I've worked for an HMO and I've worked for other people, and I just find that I just can't, I just don't settle in and enjoy it as much unless I'm the one whose skin is on the line. I want to have my skin in the game. And if somebody else's skin is in the game, I don't feel like mine's in the game as much. So I need to have my brain 100% engaged in order to enjoy that. And I also feel like I can control the situation for my patients and my referring doctors better when I'm the boss, the ultimate boss.
I've been watching the questions on Dental Town since '99, and that's my God, that's 20. I can't believe it's 22 years. And the reoccurring questions over and over is that they have all their endodontic beliefs, but there's a couple of red herrings that when they see it, they forget everything they learned. One is, one appointment or two. Whenever they see radiolucency, a periapical abscess, they freak out. Now they're like, well, maybe we should do an IND. Maybe we should put on antibiotics. Maybe we should do it in 2 appointments. But when do you switch from 1 appointment endo to 2 appointment endo?
I like the school of thought that if they're swollen or if purulent exudate comes out of the tooth and they're in a lot of pain still, I like to use 2 appointments to get some calcium hydroxide in there. I can control the situation and I can make sure they're going to heal before I say they're all done being treated. There are cases where I can't finish a case where I wanted to finish it too because it's too wet in there. Either it's bleeding or there's some weeping fluid, and then you put their sealer in, the sealer can't stick to the walls. You got to have a dry field in order for the sealer to stick. And so there are situations of pain or swelling or pus or bleeding or weeping canals that you can't finish in 1, and then you got to put the calcium hydroxide in there. But otherwise, I do try to finish them in 1. Historically, I've always liked to do all my retreats in 2. But one of the reasons that I really like the concept of the gentle wave is that I feel like we can clean the canals better. And and that we could afford to do, scientifically afford to do some of these retreatments in one case or one visit and with the gentle wave and then just be done. Nobody really wants to come back to see me, even though I'm so nice, Howard.
Back to like we were talking about losing trust. I mean, when we started Endo, like on pedo, gosh, what did we use on pedo? It wasn't chloroform. What was that stuff that we used to mummify the pulp? Was it chloroform?
Formocresol.
Formocresol. And then you had paraformaldehyde. And then I noticed that the formocresol, paraformaldehyde, chloroform, do you still have any of those in your office, or are those gone with the T-Rex?
Yep, those went with the Tyrannosaurus Rex, Howard. You should get rid of that stuff. There are still people that have it, but I don't recommend it. It had its place in an era where we didn't quite comprehend what was happening, but now on those cases, you're better off doing a complete pulpectomy, flushing it out with sodium hypochlorite, drying it calcium hydroxide in a good, solid temporary filling.
Do you ever see paraformaldehyde Sargenti root canals, or did that go extinct?
Well, I believe that's outlawed somehow in the United States of America. And so I don't know of anybody using it 100% right now, but people do still use formocresol. That's not outlawed. So
what do you and the pediatric dentist agree on for a pulpotomy?
That's been changing over last couple of decades. There are such a variety. For pulpotomy for primary teeth, people definitely still use formocresol. And there's a place for that because you're really only buying time, Howard, right? You're just trying to get that tooth to stay in there till they're 12 and it's coming out anyway. And so there's still a place for that in that era or that time frame of a child's life. But there are people that are just using some type of ferric sulfate to get the bleeding to stop, and then they're packing it full of IRM or whatever. Some of them will get the bleeding to stop, pack it full of a bioceramic, and then just do crown prep around it. But, the bioceramics take so long to set. I always worry about it not setting at all in a situation where you're really packing it super full like that.
When you do a root canal retreat, do you use the chemical to soften the Gutta-Percha?
I do, usually at least a little bit, because when you're pressing so hard on that Gutta-Percha, sometimes you can kind of unzip or strip out or transport a canal. You want to have it a little softer, so I use chloroform. I remember the first time, Howard, when I bought chloroform when I was a young dentist right out of school, I didn't believe it, that would knock you out. And so I stood over the top of that bottle and took a big old whiff, Howard. How about hit the floor? So don't ever try that at home.
Seriously, you tried that? Wow, that is cool. So, dentists want to save. I mean, a fireman wants to, the big fire, the policeman wants to catch the big criminal. And these people come in with anterior trauma. They're young kids. They snap a tooth of the gum line, and you got two schools. One's a heroic, I can save that, and root canal, post buildup, crown. And the other one's like, no, this needs to be extracted and do a 3-year bridge. And again, I keep telling the young kids that what you want to learn more than anything is diagnosis and treatment plan. If you get an A on the diagnosis and treatment plan, I don't care if you get a C on the work, it'll probably work. But if you get an A on the work and a D on the treatment plan, so that seems to be the most problem they have out of school. Like they take out an MOD amalgam and there's a crack on the floor, so they panic. They don't want to pull the tooth, but it's snapped off of the gum line. So let's address them one at a time. It's a high school kid, 18-year-old boy, snaps it at the gum line. What makes you save or extract and do implant?
The way I've read the literature and what I learned in school is that you got to have that 2-millimeter ferrule. So if it's literally snapped at the gum, then you can buy time, but you're probably not going to have it in the long run. But the way I've seen general dentists handle that is if they're going to try to keep it, they'll do those cast posts and cores and they'll lock it into place. But you're in my experience, you're basically buying time. Eventually it's going to snap off or it's going to fracture the root if there's no ferrule. With that 2-millimeter ferrule effect, as they call it, to get some crown grabbing onto dent, and then I think you can be confident that you can keep it.
And you know where that ferrule came from?
No, tell me. I remember reading about it in 1997, but
It was they figured it out on barrels that you start stacking barrels and it explode. They found out just a 2-inch little barrel ferrule around it would like quadruple the strength, and then they started splitting those in half. But that was the barrel was for ferrules. And that's where it came from. So if you do not have 2 millimeters of solid ferrule all the way around, you have to refer to a periodontist for crown lengthening. And every periodontist will tell you that 5 or 6 guys, and we're talking about periodontists who practiced 40 years and retired, that 5 or 6 guys referred 99% of their crown lengthening, and the rest don't. Do your referrals break out that way? Do you have like 5 or 6 guys that give you 80% of your business and then 20 guys for the rest? Or how does it usually work out for you?
yeah, there's something to that. I don't know the exact numbers, but I think some people call that the Pareto principle, right? Where it's the 80-20 thing. And there's certain people who run their practice and they want to be the restorative guru and they don't want to do extractions and implants. And when they send patients to me too, they want me to put the filling in the core too, because they don't want to do an occlusal amalgam. They want to do another 3-unit bridge and not be bothered with the easy little filling, which I think the patients appreciate that too. But there's other folks that try to do everything in-house, and I appreciate that as well, because I was a general dentist and I like to do everything. But I think there's probably a fine line somewhere where there's appropriate cases to refer and appropriate cases to try to keep at your place.
Another vague area, which you really can't get a straight answer, is standard of care. And it must be very confusing listening to dentists talk in the United States from other countries, because when you go to other countries, it's like all the dentists kind of are really in one country. But when you come to the United States, there's 50 different states, and the devil's in the details. And I can't even find a dental attorney that can really explain to me what standard of care is. But you keep hearing that the CBCT is now the standard of care for endo. So I don't know what standard of care is, but is it the standard of care?
Well, I had to give a lecture, Howard, one time at the AAE about what is the standard of care. And so I had to look it up and I had to talk to some attorneys and I had to try to figure it out. That has to do with some of the questions people ask me as being the dental codes rep for the AAE and stuff. And so I get involved in some of that things. And the dental standard of care seems like it's set by each judge and jury in each separate case, right? And so they'll use different things in different cases, but to me, it's not yet set as a standard of care at all. Even though I love it, I have one and I use it a lot, but it isn't the standard of care. Now, it is the state of the art. It does fall into that word. I love the word state of the art. It's even less defined. You can just say anything's the state of the art. There's no legal terminology, but it is state of the art, and I think it should be used. I think it saves tooth structure, and I think it saves us time and effort, and it helps us prevent perforating certain teeth. It helps figure out trauma cases, and if somebody's horizontal root fracture, it shows that better. It helps with a lot of different cases.
I really like that. Standard of care should be the state of the art.
Well,
is that how you said it?
I think that you can say that the cone beam is a state of the art, but it's not the standard of care. That's my interpretation of how legal words work in that scenario.
So when you go to the CBCT imaging, obviously on the unit of CBCT, some are better for full head for like orthodontics, and some are better for you going all the way down to just one tooth. What CBCT do you think is the best for endo?
In my experience, I own the CareStream 8100 model, which I'm still really fascinated with. I think it has high resolution. I do a small field volume every time. I never want the big field, and it just keeps me narrow and it keeps a high resolution. I've heard great things about the J. Merita product from endodontists, and I receive a lot of cone beam stamps from other people. I've worked with the Galileos and the Plan Mecca, and I don't want to leave anybody out, but there's a lot of other good products in there, but I like the 8100 as much as any, and I've liked what I've seen from that J. Merita high resolution product.
Yeah, that's the same one I got, and neither of us are getting paid to say Jay Marina or
No,
CareStream. Did they send you anything? Free?
negatives.
Negative? Oh, sorry, man. So do you remember Joe Dovkin?
I know the name. I never have met him.
Yeah, well, Joe Dovkin, we were at Creighton, and we were on the 9th floor of Creighton, and he became an endodontist out here, and he was a legend in endo. And that was a crazy floor. The other another guy on our floor is now a congressman in Flagstaff.
Oh,
He was a Creighton boy. And out here, we joked the Creighton Mafia, but he used to say that everyone you were either an apical barbarian and got a puffer
yeah.
sealer at the apex, or you were one of them pulp lovers. And he had the bizarrest technique. He was a squirter. And he liked that hot Gutta-Percha, and he knew that it was the hardest technique. He knew it would never go over well, but he did it all the way to his last root canal that he did before he passed away. So I'm going to ask you the Joe Dovkin series questions. Are you an apical barbarian or a pulp lover?
If I had to choose, I'm probably more of an apical barbarian. I kind of like making it a little bit bigger at the apex, but I'm changing a little because the gentle wave is allowing us to make it smaller at the apex. And so theoretically, it's getting cleaner at the apex. So I might be in a transition between, maybe I'm a lover and a fighter. I don't know.
Well, there's 50 ways to lose your lover. How many ways are there to do uptrade a root canal? And that seems to be another, it seems like there's like anything, the 80-20 rule, there's a small vocal minority of endodontists who are the loudest. And then there's 80% who just do their endo and go home. But it seems like there's a lot of people out there thinking like, say Tulsa Dental's with their 04 taper, which, they probably sold a billion of those things, that they're too aggressive, that they take out too much tooth structure, they weaken the tooth. It's a molar, it's going to be crowned. Does that bother you? Is that not conservative? Is minimally invasive dentistry coming to endo? And is it coming to endo because it's a fad or because it's a real McCoy?
I think there's something to it. There's two schools of thoughts when we get into the nitty gritty among endodontists. Some of us worry about the access opening being super conservative. People joke around and call it, some guys are doing ninja access. Some guys I've seen pictures of people doing on a lower molar, they got the mesial access and the distal access. So they're accessing the distal canal or the mesial canals. They can do it so small, it's amazing. These guys are artists and they're microsurgeons with that. And so there's the access opening minimalists. And then I like to think about the cervical, the orifice, and trying to be minimally invasive at the orifice. And so I don't use Gates Gliddens anymore, except for a rare exception on an anterior that's humongous, or a palatal root that's huge, or a distal root that's huge. But I try not to get the cervical region of any of the orifices very much bigger than an 04 taper. But if you're using a Gates Glidden into 2, and then the 3, and then the 4, well, you're making that orifice pretty weak. And there's a school of thought to think that could lead to vertical root fractures. When you're talking about the access opening, I agree. I think that the crown is taking care of your business up on the top. We worry about the crown itself, and some people just love that teeny tiny access. But for me, I think that it's got to end up leading to breaking files more or missing MB2 more if you don't have a decent size access opening to a certain minimum.
So I'm gonna go way off on the deep end on you, and just in an honest way. It's really weird, but when I was in dental school, a man that had a massive amount of influence on me was the endodontics teacher, Bambi Duro Oguntebi from Lagos, Nigeria, who's out in California now. And he said that, a long time ago, they thought this infection, maybe it came up from the bloodstream, it came all the way up. And he said they found out that indeed that was exactly wrong, and it came from the top. So when I see an MOD amalgam and a toothache, my first thought is, millions and millions of bacteria have gotten in there. So I'm going to take out, before I do the root canal, I take out the whole MOD, remove all the decay, and then prepare my final restoration. And my God, does that make endo so much easier? When I see these guys doing a root canal through a crown with an opening the size of a BB hole because they just cemented the crown. They're trying to save the crown. I'm like, I would rather pay for another lab bill than do that.
Right.
But
Right.
and then also I look at their working links and like this one's off of Cus, so it's 21. This one's off of Valley, it's 17. I mean, I couldn't even keep all that in my head. But when you when you take out all the decay and prepare your final restoration first, I think endo is easy, faster, easier, better, higher quality. Do you agree or not agree?
I think you're right. I think in many ways that I do it that way sometimes. I don't do that way every time, but I love removing the entire restoration. And when I have any doubt about if I'm not doing that because I don't want to take a crown off for some reason, if I find any doubt, then my best recommendation is, hey, I can do this root canal. I'm going to seal that off with glass ionomer over the top of it. But then I'll tell my referring dentist that crown's got to come off. You got to start from scratch on this. And you got to get everything removed. We got to go, scrap the top and get on down to the dentin and leave my Gutta-Percha alone, and let's start over. So I think starting over generally is great. You're going to find more canals. You're going to get it cleaner, and your working lengths are easier for sure.
So when you're looking at getting a second opinion, a lot of kids, they're not sure, so they send it to you. Other people are really aggressive. They're like, okay, this guy's 50 years old. The tooth's talking. I don't know if it's dead or not, but if he lives to be 80 and he's 50 and he's already old, it's talking. Some people just like, if that tooth says one word, I'm going to root canal it. How do you fill in the blanks in between those concepts?
Those are good. That's a good conversation to have. I always book like a half hour, at least maybe 40 minutes to talk with people about these things. And I'll give them their options. So if a person is in the middle of, if they're wearing a temporary crown and their tooth is chatting at them, I might be a little bit more aggressive to be doing a root canal before we put the permanent crown on. But if they just have a tooth that's a little bit funny, I'm going to present them with their options. Would you like to do a root canal to make sure that when you're on your trip to Nicaragua, that you're going to have your tooth is not going to give you a problem while you're in a foreign country? Or are you stay home body and you never leave the country and you never leave your state? And if it hurts, you're going to come call me and we'll get you in as soon as we can. So it kind of depends on the personality of an individual. I like treating people all individually, and you give them their options and they can choose.
A lot of people think that, the whole success rate is that the only reason you find the canals and file them out is to get the irrigation protocol, and that if you filed out the teeth as beautifully as you could, you probably didn't remove 2/3 of it. You have all these accessory canals and stuff, but that there's just not enough irrigation. Do you think that's a valid concern that dentists overall just under irrigate?
I probably, it's hard to know the real answer to that, but that's one of the main things that GenoWave is trying to address. You know what I mean? When I'm doing the GenoWave, I'm holding on that thing and it's running through like a liter of water, sodium hypochlorite and EDTA, and flushes it with water. There's never been a tooth I've never irrigated with as much anything as I have with my very first GenoWave case. I just hold that thing on. My wrist is hurting because I'm holding this thing on this tooth while it's pumping through a liter of stuff. And it's never been irrigated. No tooth's ever been irrigated that much before the GenoWave. I think it's a challenge. It's been studied in a lot of the endo literature and how to get irrigation to the apex. And then they talk about vapor lock. You've heard about that out there, about there's a bubble in the apex and you're not even getting new fresh irrigation up into the apex. And so it's definitely one of the main things. And that's why GenoWave has found this niche that people fall in love with when they start studying it.
And like everything in dentistry, once someone sees it, I'll give you an example with Chrysler. When Lee Iacocca rolled out the minivan, his industry is so competitive that he only got 1 year. And 1 year later, all 11 car companies rolled out a minivan. And I was lecturing in Israel just a couple months after I first saw this on Endo. And some guy already showed me a demo of something like he was making that he made himself. So I think there's going to be a lot more of these coming down.
There's one already coming out. Edge Endo is going to come out with one, supposedly.
Chuck is?
Yep.
Oh my gosh. Well, how come he told you and not me? I'm going to have to. You
got a different grapevine.
I'm going to start spreading the rumor that I like the other Guttas better.
He'll call you probably then.
My gosh. So there's also the big controversy on crowning every tooth that needs a root canal. Some people, again, there's no thinking to it. Tooth had root canal, tooth gets crowned. I get it on molars. But my gosh, on lower anteriors, these teeth are like V's. When you look at this beautiful tooth, and when I'm done with the prep, it looks like a grain of rice. It's like, if I was doing that to save the tooth, I'm going the wrong way.
No doubt.
Is that, molars obvious, but what about the front 10 teeth, upper and lower, second bite to second bite? Do those always need a crown after a root canal?
I think the studies show that they don't. So the studies that I quote talk about posterior teeth, and that's some of the studies that came out of doing dental database work with insurance companies. There's one that's Salarabi, and there's another one that's Lazarski, that are big numbers. And they showed that molars that didn't get crowns afterwards, like 85% of them were gone after 5 years. And so for molars, they have to. But the studies show that the anteriors that are not heavily restored, including the lower first premolar, those 12 teeth or whatever, 6 on top, 8 on the bottom, those 12 teeth, if they're not heavily restored, it's possible that they don't need a crown and might never need a crown if they don't have other major restorations.
So if you had 100 toothaches where they came in and they were in pain, how many of these would you not be able to get numb and do your endo? And, how often does that happen? Because it seems to be a standard complaint, going on and on. Well, I just couldn't get them numb. Is that a problem that you run into?
I don't want to sound like I'm bragging, but the last time I couldn't get somebody numb enough where they felt 100% numb and they didn't complain that I finally got them numb was probably 3 or 4 years ago. And that tooth lit me up. I was crying. He was crying. And we finally got him enough to get him out of pain, but it was tough. What I use is my last weapon is an intraosseous injection. So, and I use I'm a lidocaine guy, but on a lower molar, that's what we call hot. It's a hot lower molar, number 30 or number 31. I do 2 blocks in more of like a modified Gow Gates. And then I do a buccal and a lingual infiltration with articaine. I don't use articaine in a block, but I do buccal and lingual infiltrate. And then I do a cold test. And if they feel the cold, then I do the intraosseous. And if they don't feel the cold, then I'll try it. And if they feel anything during the process, I take the dam back off and I do the intraosseous.
There's, again, these podcasts, the internet doesn't know nationalism. And I love that about the internet. It doesn't care if you're Canadian or where you're from or whatever. But when you go around the world, especially when I was in Asia, like Cambodia, Myanmar, places like that, a very common question they ask is, why do Americans love bleach so much? The bacteria are anaerobic, so they use H2O2, hydrogen peroxide. Some dentists say, well, I do it with bleach, and then I do it with chlorhexidine, then I do it with hydrogen peroxide. Do you only use bleach, or do you ever use the other ones?
No, I think that's a good question. The studies show on that question is that sodium hypochlorite is the best irrigant. But if you think about sodium hypochlorite, you know why it's effective against the anaerobics is because it introduces oxygen the same. So it's the perchlorous ion or something like that introduces oxygen into the system down low. So it still introduces oxygen just like hydrogen peroxide. The problem is that if you're not careful with sodium hypochlorite, then you can have an accident. You can have either a tasting accident or an injection accident, and you just don't want to go there. And so it's also been proven that the higher percentage of sodium hypochlorite is more effective, and that warming it up also is more effective. So all these things point to sodium hypochlorite. But I also think that there's a place for EDTA. EDTA removes the smear layer. You remember about the smear layer. And then on certain cases, I also like 2% chlorhexidine. And so you don't want to mix the sodium hypochlorite in the chlorhexidine, though, because they'd make a sludge, a brown-orange sludge. So never do that.
Yeah, I think the question also comes from the fact that dentists are afraid of bleach. They're afraid of sodium hypochlorite. And I think one of the reasons they under-irrigate is because they're afraid.
No doubt.
They're just afraid. They're afraid of the drug. How often do you have a sodium hypochlorite accident is
a
it still
tasting accident?
Yeah, tasting.
Again, there's two different ways. There's the tasting accident, which is not a problem if they taste it and you get it out of there before it gets in their throat. If it gets back to their pharynx, it's going to burn. It doesn't feel very good. I've had 2 or 3 of those through the years when I didn't have a good enough dental dam on. If you're using sodium hypochlorite, you just should have a dental dam on. I've never had, knock on wood. Now you're telling me, you asked me this question and now I have to knock on wood because I don't ever want a real hypochlorite accident. I've never had one. And now I got to knock on the wood because I never want one. These could be major problems for a person as they heal up, and they can have necrotic skin underneath, and it could be a serious problem.
So people in the practice management DSO world about endodontists, I mean, it's kind of funny things they'll say to you on the phone or at lunch that they won't say on a podcast, but they say, this is what they'll say, well, if you get one of the microscope guys, my God, they can only do 4 or 5 molars a day. But if you get one of those guys that doesn't have a microscope, and you have a busy day, they might do 8 or 9 a day. And some people say that the microscope, that if it wasn't for the microscope, endodontists would make almost as much as oral surgeons. And so do you think the microscope, it obviously has slowed down a lot of people? If you, again, I keep going to this 100, if you did 100 molars, how many would you whip out a microscope?
100, Howard. I'm 100 for 100. I'm in love with my microscope and I call her honey. I use it all the time, every case, not during every moment of every case, but every case I use a microscope, even a simple number 8. I feel like I miss stuff if I don't use it, but I don't want to throw anybody under the bus that doesn't use it 100% of the time. But I know it slows me down, but I feel like I do better work at that pace and with using the microscope to work.
And what are you usually looking at? How many Power X are you up usually? 6X, 8X, 12X?
Yeah, it's like 8, I think, is what I'm usually on.
Yeah?
Yeah, it makes it look about as big as a softball to a volleyball. That's how I explain it to the patients.
I think the best thing about microscopes is they teach us to enjoy the little things in life.
Good point.
So what microscope did you go with? There seems to be 2 major ones. There's one out of St. Louis. That's a little lower cost. There's one out of Germany. It's a little higher cost, Mercedes. Yep. Which one did you go with? I
have a couple of each. I got one in each operatory. I have a brand new Global. I have a fairly new Zeiss and 2 older Zeisses, and then I have another older Global. So I got a little bit of everything. For me, the real trick is the light source. The better your light source, the better your world is. If you can get an LED light source of the nice white light, you're going to like your scope better. I also think that general dentists using microscopes, they're going to start liking it too. But it might slow them down as well. And, you might not really want to afford that slowing down. You have to make a decision about that.
I'll tell you, the Zeiss microscope, you know what made me realize, how I fell in love with Zeiss is it wasn't, had nothing to do with dentistry. It was for their binoculars. And awesome. A lot of, from Kansas, a lot of people like to go hunting. My oldest son, I got 4 sons, the oldest one loves to go hunting. And, I don't want to shoot a deer or elk because I'm not going to eat it, but I'd throw a grenade at a cow. I mean, I could eat hamburgers and steaks all day long. But I don't even like buffalo. But those Zeiss microscopes, you know, animals only move at sunbreak and sunset. And like a half hour before the sun comes up, those Zeiss microscopes, it looks like it has night vision. In fact, when I first looked at them, I thought maybe it was night vision. It's just so damn good. But if you take those to a professional sporting game, I mean, you could, I mean, it's just crazy optics on how that is.
They're
But
amazing.
but the microscopes are the best. So microscopes, standard care or state of the art. If a dentist doesn't refer any of his endo, he says, I do all my own endo, and let's say he does 7 a month, which is kind of the bottom floor. A DSO won't even hold on to a general practice if it's not doing 7 root canals a month. They don't even think it has the fundamental demand. Do you think they should get a microscope?
I think you should consider getting the microscope. This, Howard, is right on the edge of where it might start becoming standard of care. It's not standard of care yet, I don't think. Like the dental dam is called standard of care. That I think you can say is standard of care. The microscope is becoming more likely to eventually be standard of care. The American Association of Endodontists came out with a new position paper on that the last year or two. I was on that committee. And the previous paper, I was also on the committee, and they didn't want to make any strong statements because we still had a lot of our own members that weren't using microscope. This latest paper, though, comes out a lot more strongly in favor of magnification of all types, at least, and illumination of all types. Not just the microscope, but of serious magnification, not just 2.5 or not just 3.5, even though those are good, but something better. And so in the future, it could be, and I just think that people are going to like it better. I feel like they're going to feel like they get everything better. They're going to feel more like they did it right. They saw that they did it right. They got no voids. They found all the canals. They know they're right.
It's interesting at the board where so many times that people get in really big trouble at the board, and you got to remember, I've been a dental journalist since 1994. I've had my own publication.
Right.
I started in 1994. I mean, now it's 2021. But when you're a dental journalist, you live in a different world, and dental malpractice people going way back to 94 would start sending me their monthly payouts and their claims, and if I've learned 2 things from that, it's my God, you're not an anesthesiologist, and whenever you see $1 million, $2 million, $3 million settlement, somebody died, and when somebody died, they always have an IV in their arm, and you are in the field where people are in the most pain. They have a lot of anxiety. They're afraid of the dentist, which is why it led to this. Have you been tempted to learn IV sedation? Do you use IV sedation? Do you ever put people to sleep? Do you have an anesthesiologist come in? Any of those thoughts?
I've thought about doing that, and I have a couple of my friends that are general dentists that have gone back to class and get their license to be able to put people to sleep and do the work like implant work, surgical work, or whatever, operative work. And at this point, I've decided that I don't want to do it, but I do incorporate it into my practice. We bring in there's a couple of different practitioners that are dental anesthetists that are booked out and very popular in demand on here in Portland, Oregon. They're both excellent, Sophia Tan and Ryan Allred. And I just did a case a couple weeks ago on a child that needed to be sedated. We did number 8 and 9. She put her to sleep. I did the work, and she did all the post-op. And so I was in and out of there in an hour and a half, and she took care of all the stuff that I don't know how to do. And so I definitely like the ability to bring in the dental anesthetist, but I'm tempted. Yes, I like learning about that stuff, but I just don't see how it's going to fit in my flow very well yet. You know what I mean?
Right. The other one is, obviously shit happens. I mean, shit happens. Life happens. It's not always pretty. Life's complex, but they get spanked because they didn't refer. They're like, God, what had to happen before you finally sent it out? Well, I know dentists, and I think a lot of reasons they don't use consultants because they're embarrassed. They don't want to have the consultant come in. It's so messed up. And he's sitting there looking at this big mistake, and he knows Kenny's up the street, but Kenny's been up the street for 10 years. He's going to be there another 20 years. He doesn't want every time you see Howie to sit there and think, oh, I remember the last case I got from Howard, that idiot. He's third eye blind. What advice would you give for referring? When do you need to refer, and when do you need to check your ego and say, hey, enough's enough? It's patient-centered, patient first. It's the same thing with dental insurance and DSOs. When people talk about what they don't like about DSOs or dental insurance, I'm like, look, if everybody would just keep one eye on the patient and one eye on cost, and everybody works hard to make everything faster, easier, better, higher quality, lower cost, we're all on the same team. We're all on the numerator side, but it's all divided by the patient. So that patient sitting in the chair, when should that doc say enough's enough and refer to an endodontist?
What I used when I give advice to that, I tell them to use two tests: the mirror and your mom. So the first thing I do is, would you do that root canal on your mom? And the second one is, look in the mirror. Would you do that root canal on yourself? And so if they can say, if my mom was in the chair, I'll do it for her, then they should do it for the patient. The patient wants them to do it for them. They don't want to have to go meet me. I'm a real nice guy, but they'd rather have their own guy or girl do it. And so if they're going to do it on their mom, and it's this patient's in the chair, they can do it. They should do it. And same thing with the mirror. So I just like that catchphrase, the mirror and your mom. So
wow, I had no idea where that was going when you started. I thought, did he just say mom? That's funny. Yeah, and I my sister always reminds me. My two older sisters went to the nunnery straight out of school, and my oldest sister knows multiple languages, and she said when you read Hinduism, Islam, Judaism, Christianity, when you leave all the major work, there's not a single name of a person, place, thing, city, nothing, except for the golden rule. Just treat other people like you want to be treated. And it's so easy. So when you're working somewhere and they're doing something to where you wouldn't do it on yourself or your mom, you gotta change directions. So what do you think are the what do you think the biggest controversies in endo? Like if you switch to pediatric dentistry, I never thought they'd have a controversy. And then silver diamine fluoride came out of nowhere, and sure enough, it just divided them. With implants, initially, it was mini implants and root form implants, and those two groups couldn't even be in the same room. Is there anything in endo where you feel, what is the most controversial things in endo?
Well, I think that one that started kind of when I was a resident down in San Antonio was that there's that one trend that happened where a lot of people were feeling like they were just pulling teeth that already had root canals and not giving them a chance to be retreated. Instead, they're just taking them out and putting an implant. And so for a while, there was a big controversy among endodontists that we were getting left out of the loop as far as getting a good chance of retreating a case that was done poorly at the first time and should be done better and keep it. But I think a lot of endodontists feel like the pendulum's swinging back toward the middle on that one. But in 05 to maybe 2015, it was swung way over to just pull it. And now I feel like it's swinging back, and that people are trying to keep those teeth that had a poor root canal the first time around. Let's get a better root canal and give it a try. So that was controversial. I feel like it's coming back toward the middle and making good decisions for the patient instead of just pulling the tooth. The 1 versus 2 visit is always a controversy among endodontists. We love talking about it. We love speculating about it. People love talking about the gentle wave as a controversial. Should I buy it, or is it a big paperweight? So those are the things we like to talk about in endo. And one of the reasons, Howard, I wanted to get into endodontics is that it's binary. It's not that complicated. It's a yes or no business. You're not talking about colors. You're not talking about making somebody feel bad that their teeth are ugly, or like you always say, I'm not going to tell a pretty woman that she needs to bleach her teeth. I'm never going to tell somebody that. I'm just going to ask her, does she want to keep her tooth?
Right. And that's why I don't like to sell dentistry. I mean, I don't want to start recommending that people do bleaching, bonding veneers. And I also know that it's hypocrisy where when I got out of school in 87, dentistry wasn't very conservative, and there's all these cosmetic dentists and people come in with gnarly teeth, and they'd file them all down and do 10 unit to PFMs upper and lower. But I noticed when their daughter had really gnarly teeth. She got 2 years of braces and bleaching.
Right.
And so it's kind of like, so I could see it, teaching your
Yep.
daughter that. So I think I finally figured out why endodontists will only use one mouthwash, the scope, because it's microscope. Yeah. Is
Yeah, there you go.
is that why you use scope? You think it's better under a microscope? When dentists evaluate, when I got out of school again, there was still some Sargenti. I'd say it was about 10%, and they were in small towns. And literally in towns of 5,000 or less, and the dentist just did them out, so they went away. But what I noticed the most, before that, there was also the silver points.
Yeah.
Do you ever see silver points anymore that are in old teeth?
Yeah, we do. There's a school of thought about silver points. Some people thought they should just pull them because they're there, so they were just retreating them, even if they're asymptomatic with no lesion. But the school of thought that really has won that day is over. Let's wait them out, right? Some of them have worked. Why are you going to redo it? Now, sometimes we'll want to redo it if we're going to replace the crown, because now is the time. So you get a better root canal on there now because we're in there. But if the tooth doesn't need addressed with a new crown and there's no lesion on it, no symptoms, then I think most endodontists are saying, just leave that alone until you have to.
Well, the thing I learned from the silver point is that, when I moved out here to Phoenix, it's a retirement area. It's like, if you're west of the Mississippi, you go to Florida, and east of Mississippi, you go to Florida, and you're west, you come out to Arizona. And I saw so many 70, 80, 90-year-old people with these silver points that looked like they couldn't have been bigger than a 20 or a 30 file.
Yeah.
And they've been there 40 or 50 years, which meant what the endodontists used to tell us in school is when you'd ask them what type of sealer to use, they'd say, well, if you find all the canals and get it all cleaned out, I don't care if you use bird shit, and just make sure it's sterile bird shit. Be sure to autoclave the bird shit first. But it just showed me, okay, this root canal's lasted 50 years, and it doesn't look obturated, and it must have been cleaned and shaped very well.
And probably was vital to begin with, not necrotic to begin with, right? Not necrotic pulp to begin with.
So, do you think that's another big factor in that?
Yeah, that's been proven to be a big factor in literature, in the studies of endodontic literature. Definitely a tooth with a preoperative pulp necrosis diagnosis has been shown to have kind of a 10% lower chance of success, especially if you don't get a good quality root canal on there. But it makes sense because there's already bacteria in all the nooks and crannies, right? And so if it's vital down there, it doesn't have bacteria in the nooks and crannies. As long as you're using a dental dam and you use bleach in there, it should stay sterile. So then it makes sense. You could put whatever you wanted to in there.
Right. So I can't believe we went over an hour. My God, that was the fastest hour of my life. I love talking endo. You had to shut down for 2 months in Oregon because of COVID. Did the governor shut you down for 2 months?
It wasn't quite 2 months, but it's an interesting story. In the Portland practice, we shut down fully for like 10 days. But Howard, I was on the phone for 2 to 4 hours every day that we were shut down. My phone was ringing off the hook with swollen faces and like grandma who didn't know what to do, but she knew she wasn't supposed to go to the dentist. So I had made friends with the pharmacists. I was calling the pharmacy so many times and prescribing antibiotics for all these people. And I kept a spreadsheet of who needed to be followed up. So I was calling people. And finally, they kind of opened it up a little bit here in the Portland area, and we had to see the true emergencies. But we have a practice out in Astoria, and as a group, all the dentists of our county, of Clatsop County out in Astoria, Oregon, which is where they filmed Kindergarten Cop, way out in the boonies there. It's not the boonies, but it's far away. I love Astoria, shout out. But we shut it down for like 6 weeks. All the dentists shut down, but we made one kind of dental hospital that they rotated somebody through for true emergencies. And then if they had an endodontic emergency, they sent them into Portland, and me and my business partner worked on them there.
And now that you and I have both had both doses, and we're coming up on a year of the pandemic. It was early March, and this is what is this? February 2nd. Are you bullish about 2021? There's a lot of talk now that there's a UK variant, a Brazilian variant, a South African variant. from where you see it right now in Oregon, does it look like 2021 is going to be better than 2020? Do you see light at the end of the tunnel, or do you feel like you're still in the middle of this damn hurricane and it's still every day?
I guess I'm used to the hurricane. You know, I think I have a dent in the top of my head from my N95 mask, so I'm kind of used to it. It hurts a little bit, but it doesn't hurt that bad anymore. I got a headache, but it's not that bad. I don't know. I don't see it. I don't see the numbers breaking in Oregon yet. I don't think they're testing as much, so the numbers look like they're lower, but the deaths are lower. They have gone lower. The hospitalizations are lower, but I don't honestly know. I was talking with when I was on our Board of Endodontics call the other day for the AAE, somebody brought up the fact that they thought that this might be something like this might happen off and on for the next 30 years due to globalization and overpopulation and stuff like that. And so I don't know if that's true, and I don't know where they got the 30 years number from, but to me, it makes a little bit of sense. I mean, we're all one big family now, one big happy family coughing on each other from China to Timbuktu to Orlando to Portland, Oregon, and things get around.
Yeah, it's crazy, and when they still think where I was born and raised in Kansas that's where the Spanish influenza started. They think it jumped from a pig, and I read the whole book on it, and they think it went from a pig to a farmer, and then he was drafted to Leavenworth, and then they were rolled out to Europe, and so when I hear my mom blaming this whole thing on the Chinese, I'm like, Mom, you're from Kansas. I mean, I could hear you saying that if you're from Iowa, but you can't say that if you're from Kansas. But these are just truly just unbelievably interesting times. And I want to thank you so much. I mean, you've had a very long day. The last thing you need to do is come talk to me and my homies for an hour, and we even went in overtime. But I just really have a strong urge to try to get doctors to do endo because, in fact, that's my final question. Let's say they decide, look, I'm not doing molar endo. Okay, but you're a real doctor. You're public health. You're a point of availability, accessibility. They're coming into the office. They got a severe toothache, and they're not going to be able to get into your office for 3 days.
Right.
What does he have to do? What should he be able to do as a doctor of dental surgery to tie this person over? Because I know what they're going to do. They're going to give him Pen-VK and Vicodin. And is that a standard of care? You're in toothache, you're in pain, I'm just going to give you Pen-VK and Vicodin? Or what should they do to hold them over till they see you?
Well, I know what we teach at the university here in Oregon is everybody needs to be able to do at least a pulpotomy for a vital pulp, and a pulpectomy for a pulp necrosis diagnosis or an abscess diagnosis. And so I guess the bare minimum that your dental school professor would say is you got to know how to get them numb enough. Like we talked about earlier, you might need to know how to do an intraosseous shot. You got to know how to put a dental dam on there and get in there and get the pulp out of there, whether it be pulpotomy or pulpectomy. And then also consider prescribing appropriately. But also, I think that you ought to go and meet your local neighborhood oral surgeon and your local neighborhood endodontist and make friends with them, or tell them that you're there and that you do or don't like doing this, and help make yourself those boundaries that you use to decide what cases you are going to do. If it's zero or if it's you're going to do them all, kind of bounce it off of that girl or that guy that does it professionally, and make that relationship. So I look forward to making relationships with the new folks in the area, not because I think they should be referring more, but because I think it's good for all of us to build that community.
And what he said was very, very profound. What I don't get is why every time you want to learn something, you got to go to the airport, fly across the country, drop $3,000 on the weekend, and learn over there. And just on your way to your airport to learn about implants, how many periodontists and endodontists did you pass on the way? And that guy lecturing at this institute, he's not going to be there when one of your patients has an emergency. I mean, it's just, if you want to learn implantology, just go tell your periodontist. But they're afraid. They're like, well, he wants to do all the implants. He's not going to teach me how to take away food for him. And final question, I swear to God, I know it's late and you want to go home. But some dentists say that if I refer you 100 molars, you'll do 100 root canals. That if you send 100 consults on these wisdom teeth to oral surgeons, all 100 to get extracted, and maybe a better endodontist is one that could say, well, I'm not going to do the root canal, I'm going to extract it and do an implant. But then endodontists tell me that if they started doing that, it would be channel conflict, and they'd immediately lose all the referrals of endo from periodontists and oral surgeons and all that. Are you, obviously the microscope took off in endo, the CBCT, lots of things have taken off. Do you think endodontists placing implants is really going to take off and be a thing to where a generation from now they'll all be able to place implants, or do you think that's too much channel conflict?
I think that's a great question. Maybe that's one of the controversies that we should have talked about earlier. But having been a general dentist for 7 years myself, I went to endo school because I chose not to go to learn how to put implants in, right? I could have chosen to go be an implantologist at that point. So I chose that I liked this other skill. And so when I looked at learning how to do implants as already being an endodontist, I kind of said, well, I already made my decision. I want to do root canals. And I feel like the skill sets are so separate that I want to play my game. I don't want to play a whole nother game and keep the inventory for a whole nother sport in my office. But at the same time, I like the fact that some endodontists do want to do it. And I don't want to, send them down the road and say, I don't think it's a good idea. Because sometimes the scenario where I think it's great for an endodontist to put in an implant is when we reflected a flap. I got number 9. I didn't think it was fractured, and now it's fractured. What if we could bury an implant right there when I know it's fractured? The problem is that it's hard to do the informed consent for all those different things, but beforehand. And so if I reflect the flap, now it's fractured. Now I gotta sew them back up. Now they got to heal, and then they got to go get the tooth out and get the implant. Those are the cases that I kind of wish I could figure out, but those are hard ones to figure out. Overall, though, I chose not to really learn how to do implants. I don't know what it's going to happen in the future on that one.
Yeah, it is. Channel conflict is a real thing.
Yep.
I mean, money's the answer. What's the question? Yep. And the other thing I touch on is you don't want to have a heavily indebted doctor. I mean, these student loans scare me with these kids. I mean, if they come out $400,000 of student loans and they have a student loan payment this big each month, could that MOD onlay from CAD/CAM, could it have just been a direct composite?
Right.
I don't, there's pros and cons to everything. I trust my homies, but you don't want desperate people. But Ken, seriously, man. And by the way, I'm a dentist because my next door neighbor was Ken too, Kenny Anderson. He was a valedictorian from Creighton. And I'd go to work with my dad and make hamburgers and hot dogs at Sonic. And then I'd go to work with Kenny. And he had this x-ray machine, and it would look through teeth, and you'd go in the dark room and develop it. And he did his own root canals. And my gosh, it's just a great profession. And it's because guys like you are always fighting for it. But thanks for all you do, Ken. Thanks so much for coming on the show at the end of the day. And good luck with your students at Oregon Health.
Hey, thanks. I appreciate being on. It was fun to talk with you. I appreciate it.
Okay. Have a great day, bud.
You too. Have a good one. Bye.